Coming up the group of the connective tissue panniculitis, this group includes panniculitis like the scleroderma panniculitis, lupus panniculitis, dermatomyositis associated panniculitis, annular atrophic connective tissue panniculitis, and atrophic connective tissue panniculitis. The common features in these have the lymphoid follicles with a hyaline necrosis. The scleroderma panniculitis will have the clinical features of the indurated plaque, which is located mainly in the extremities and the trunk. This is seen more in the case of the morphea than the systemic sclerosis, and it is a septal panniculitis without vasculitis. Lupus panniculitis presents as a tender nodule and the plaque mainly located over the cheek, upper outer arm, shoulder, breast, hip, and the trunk. It is seen more in cases of the discoid lupus erythematosus than the systemic lupus erythematosus. Is it considered to be lobular or the mixed type of panniculitis, which have the other features like the mucin deposition, hyaline necrosis, lymphocyte and plasma cell dominant, CD123 plasma cytoid dendritic cells, and the nodular lymphoid aggregate forming the lymphoid follicles. Dermatomyositis associated present with indurated painful plaque and the nodule, it may ulcerate, and usually it follows or the precedes the dermatomyositis manifestation. It is also the lobular, the mixed type of panniculitis. Annular atrophic connective tissue panniculitis present as a tender indurated plaque having the subcutaneous atrophy presented over as a circumferential band around the ankles. Atrophic connective tissue panniculitis present as a erythematous indurated plaque and subcutaneous atrophy and is usually widespread and can be located in the extremities. It is related to the antinuclear antibody presence, autoimmune thyroiditis, and the rheumatoid arthritis. It is also the lobular or the mixed type of the panniculitis, which is the lymphohistiocytic infiltrate rich. Coming up the group of the panniculitis which have the needle separate cleft on the histology in the subcutaneous. These includes the subcutaneous fat necrosis of the newborn, scleroderma neonatorum, and the post-steroid panniculitis. These panniculitis have the common features of the histopathological finding, which is the needle separate cleft within the lipocyte. This needle separate cleft is basically that crystallized triglyceride because of the adipocytes crystallization. First is subcutaneous fat necrosis of newborn. It is found in the full term neonate, usually seen 2 to 3 weeks, third week of the life, and it is present as a circumscribed erythematous indurated nodules. Basically starts from the shoulder, common in the shoulders and the buttock, can be seen in the cheeks, back, and the thigh. It is a lobular panniculitis with the neutrophils and lymphocyte macrophages. The basic etiology of the subcutaneous fat necrosis of the newborn and the scleroderma neonatorum is because of constituent of the neonatal fat, which is high in the saturated fatty acid and low in the polysaturated fatty acid. Because of that, when the temperature lowers down, it solidified easily and leading to the necrosis of the adipocyte and the subsequent inflammation. So the basic etiology lies because of the hypothermia, hypoglycemia, perinatal hypoxia in case of subcutaneous fat necrosis of the newborn. Scleroderma neonatorum is usually present in the premature neonate which is severely ill, and it is present in the first week of life, and it usually starts from the buttock and is spread widespreadly diffuse hardening and spares the area of the palm, soles, and the genitalia. Whole of the entire skin surface appears waxy, rigid, and board-like with a purple mottled discoloration and a cool in touch. As the presentation is diffuse, but on histopathological finding, inflammatory cells are sparse to absent. Whole of the fat lobules is replaced by the amphiphilic granular detritus with a needle separate cleft in the lipocytes, and also present with the septal thickening. It also because of the hypothermia, perinatal hypoxia, defective complement, and dehydration. Post-steroid panniculitis is seen in the age group of the children 1 to 14 years, basically because of the rapid withdrawal of the systemic corticosteroid, usually seen within the 1 to 40 days, usually within the 10 days. It presents as a firm red plaque on the areas where the fat deposit following the systemic corticosteroid therapy, including cheeks, arms, and the posterior neck. It is also the present with a needle separate cleft in the lymphocytes and the giant cells. It is a lobular panniculitis with the lymphocyte, macrophages, and multinucleated giant cells. Coming up the additional features of subcutaneous fat necrosis of newborn. This case associated with the complication of hypercalcemia is because of the extrarenal production of the 1,25-dihydroxyvitamin D because of the activated macrophages, and usually occurs within the 2 months. And the cytopenia because of platelet sequestration, and the hyperglycemia because of the maternal diabetes. Usually it is a self-limiting condition, and so as the hyperglycemia is a complication of this disease, so observation for the hypercalcemia should be taken care, and one should avoid the vitamin D3 and the calcium. Calcium wasting diuretics can be used like the furosemide and the bisphosphonate, etidronate, and the pamidronate can be useful in the severe cases. Even the systemic corticosteroid can be given in the severe cases to subside the inflammation and to limit the hypercalcemia. Scleroderma neonatorum is a grave illness, and its death is usually from the septicemia, and usually treatment lying on the underlying condition like treatment of the septicemia. Post-steroid panniculitis usually the self-limiting condition, and it disappears without scarring within the weeks of the month. The picture showing the subcutaneous fat necrosis of the newborn on the firm erythematous nodule on the back and the shoulder, and the histopathological image showing the little separate cleft within the adipocytes. Now coming up the next entity, the pancreatic panniculitis. It is associated with the pancreatic diseases like the chronic and the acute pancreatitis, pancreatic cirrhosis, pancreatic carcinoma, pancreatic anomalies, and the various drugs like the azathioprine and the SLE, hypertriglyceridemia, nephrotic syndrome, HIV, and the L-asparagine treatment. When a panniculitis patient coming up with a fever, polyarthritis, and abnormal weight, one should suspect a pancreatic disease, and one presented with a panniculitis and polyarthritis and the eosinophilia. This is a skimmed triad which is seen in the pancreatic cancer. And there is one patient coming with the features of the symptoms of the pancreatitis, panniculitis, and polyarthritis comes under syndrome. This is triple P syndrome. Clinical features of the pancreatic panniculitis include the multiple tender red or the red-brown nodules, which has tendency to ulcerate and fistulation, and it drains oily brown sterile viscous material and is typically located over the distal part of the lower extremities around the ankles. Pancreatic panniculitis is the predominantly lobular panniculitis without vasculitis. The characteristic finding of the panniculitis is the ghost adipocyte in the saprophyte fat globules, which is shown in the histological image, and the granular or the homogeneous basophilic necrosis. For the management of pancreatic panniculitis, investigation part usually seen the elevated serum enzyme level like the lipase, amylase, and trypsin in the blood, urine, and even the skin lesions. Leukocyte reaction and eosinophilia in the peripheral blood can be seen in the pancreatic cancers. And the treatment includes the supportive measures and the treatment for the underlying pancreatic disease. One can give the somatostatin analog octreotide to inhibit the pancreatic enzyme secretion. The usual treatment of the panniculitis, which we usually give, is corticosteroid, NSAID, and immunosuppressive, is not effective in this case. Now coming up the next entity is the alpha-1 antitrypsin deficiency panniculitis. It is autosomal recessive inborn error of the metabolism. And because of deficiency of the alpha-1 antitrypsin, there is uncontrolled activation of the lymphocyte and the macrophages, lack of inhibition of the complement cascade including the C3A and C5A, neutrophilic chemotactic factor, and because of that accumulation of the neutrophils with the release of the proteolytic enzymes and leading to the secondary tissue changes. There's a gene homozygosity for the Z allele alpha 1 PIZZ is associated with very low level of the serum level of the antitrypsin 20 to 45 milligram of the milligram per dl. Normal value of the antitrypsin is the 100 to 200 milligram per dl. Clinical features: alpha 1 antitrypsin is a large erythematous purpuric tender nodule of the plaque which ulcerate and exude oily material, is located in the lower trunks, proximal extremities, basically the flanks, the buttock and thigh. It is a chronic relapsing cause and the scarring atrophy is common. Histopathologically, it is predominantly lobular panniculitis with no vasculitis. The characteristic feature of the splaying of neutrophils in the lower dermis and the presence of escape areas of the normal adipose site. Because of the intense inflammation, there occurs the septal collagenesis and the elastic tissue degeneration. Later stages, non-specific changes, lipophagic granuloma, which replaces the fat lobules. Treatment part include one should avoid trauma, surgical debridement, smoking or the alcohol intake. In this entity also the usual treatment of panniculitis, that is the corticosteroid, immunosuppressive drug, colchicine and antimalarial gives them poor or no response. Doxycycline or the minocycline given the dose of the 200 mg OD for the at least for 3 days gives the response, and dapsone also shows a response. Ultimate treatment include replacement of alpha 1 antitrypsin, plasma exchange and the liver transplant. Coming up the infection in this panniculitis, various infections can cause this panniculitis include the bacteria, Mycobacterium, Coxiella, Borrelia, fungi and the helminths and protozoals. Clinical features of this entity, it is usually seen in the case of the immunosuppressed and the diabetes mellitus patient. It presents as a local swelling erythematous fluctuant nodules that ulcerate and drains on the lower leg and the feet. Usually diagnosis based on the spatial staining for the organism and culture of the drainage and the tissues are the key for the diagnosis. Histopathologically, it is found to be mixed septal and lobular panniculitis having the neutrophilic infiltration, vascular proliferation, hemorrhage and necrosis of the lipocytes with the involvement of the eccrine sweat coils. In case of the infection with the Coxiella burnetii, donate like granulomatous lobular panniculitis, fibrin and the inflammatory cells form a ring around the central clear space. Stenotrophomonas maltophilia forms the foamy histiocyte cytoplasm filled with the bluish granular material phagocytous bacteria. Mucormycosis present with the ghost cells and the granular calcium deposit. Treatment of this entity includes appropriate antimicrobial therapy depending upon the infection. Coming up with the cytophagic histiocytic panniculitis, it is a subcutaneous present as subcutaneous nodule in the plaque that on histology shows the inflate of the macrophages containing erythrocyte, lymphocyte and karyorectic debris that is exhibiting hemophagocytosis. Macrophages with the cytophagic activity known as the bean bag cell, which is shown in the histopathological image. There are the two types of the primary lymphoma affecting the subcutaneous tissue which present as the cytophagic histiocytic panniculitis include subcutaneous panniculitis T cell like lymphoma, primary cutaneous gamma delta T cell lymphoma, which are the poor prognosis associated with the pancytopenia, hemophagocytic syndrome, which also involves the liver and the bone marrow. To conclude, the panniculitis, which is broadly divided, there is no purely septal or the purely lobular panniculitis and have the diverse etiology which resembles closely to each other, presenting as a standard erythematous subcutaneous nodule. Diagnosis based on the partly by the clinical characteristics, partly by the histopathology, partly by the etiology. And the biopsy should also always include a generous portion of subcutaneous fat. Excisional biopsy is narrow incisional biopsy preferable over the punch biopsy, and management includes the two therapeutic considerations: specific panniculitis treatment and the treatment of the underlying illness. Thank you.